Okay, picture this. It's the 17th century, and this physician, Jan Baptist van Helmont, comes up with this, well, pretty radical idea for medical research.
Uh-huh.
He basically suggests, let's take patients, divide them up just by casting pure chance. Give one group my treatment, the other gets the usual stuff.
And the goal.
His goal, and this is a direct quote apparently, we shall see how many funerals both of us shall have.
Wow. Bit grim, but...
A bit grim, yeah.
Oh, yeah.
But honestly, it's like the earliest glimmer of what we now call a randomized controlled trial. The absolute core idea is right there.
Amazing.
Welcome to the deep dive.
Yeah.
Today, we're really getting into the weeds on randomized controlled trials, or RCTs.
That's right.
We're using a chapter from this academic work, Applied Causal Inference, powered by ML and AI, by Viktor Chernozhukov and his colleagues, as our main guide.
Mm-hmm.
And our mission really is to unpack how these trials let us figure out cause and effect, like really figure it out. We'll look at how they're used in some super important real-world cases, but also, and this is key, where they fall short, their limitations.
Yeah, because it's not just about stats, is it? It's about understanding what actually works.
Exactly.
And you'll learn about this core concept called potential outcomes. Why just looking at data you happen to find can really mislead you.
All right.
And how the, I guess, elegant design of an RCT just cuts through all that confusion. We've got some great examples, vaccines, unemployment programs.
Oh, yeah.
And we'll definitely get into why even this gold standard isn't always the perfect solution. It has its own Achilles heel, you could say.
Okay, let's start unpacking that, this core challenge.
Yeah.
We want to know if X causes Y, right? Does this training program actually cause people to earn more money?
That's the fundamental question.
But the problem is we only see one reality for any given person. We see they either did the training and got a certain wage, or they didn't do the training and got a different wage. We can't see both worlds for the same person.
Exactly. You can't simultaneously be in the program and not in the program. It's impossible. This is where the potential outcomes idea comes in.
Yep.
So imagine for each person, there are these two sort of hidden, unobserved possibilities. What their outcome would be if they got the treatment, let's call it Y1, and what their outcome would be if they didn't, Y0.
These are the counterfactuals, what might have been.
Precisely. They're counter to fact because you only ever see one of them. The actual individual treatment effect is just the difference, Y1, Y0, but like you said, we can almost never know that for one specific person.
Okay, so if individual effects are basically off the table, what do we aim for instead?
We shift focus. Instead of the individual, we look at the average effect across a whole population. This is the average treatment effect, or 8EE. We usually call it delta.
Right.
It's simply the average of all the Y1s minus the average of all the Y0s. It tells us the average causal impact if we were to, say, give the treatment to everyone versus no one.
Makes sense. And you mentioned assumptions earlier. To even talk about these potential outcomes, Y1 and Y0, what needs to hold true?
Yeah, there are two key assumptions bundled together under the name SUTVA, Stable Unit Treatment Value Assumption. It sounds technical, but the ideas are pretty intuitive.
Okay, break it down for us.
First is consistency. This just means your actual observed outcome, Y, is exactly your potential outcome under the treatment you actually got. So if you got the treatment D1, your outcome Y is Y1. If you didn't, D0, your Y is Y0. No weird variations in the treatment itself.
Simple enough. What's the second part?
The second is no interference. This one's crucial. It means my getting the treatment doesn't change your potential outcome.
Ah, okay. Like with a vaccine, in theory, me getting vaccinated shouldn't directly change whether you would get sick if you remained unvaccinated, although we might come back to that later.
Exactly. We'll definitely circle back to that nuance. But for defining the basic potential outcomes, we assume no interference.
Got it. Okay, now, here's where things get really interesting, and maybe where a lot of non-RCT studies, observational studies, go wrong. In those studies, where people choose whether or not to get the treatment, we often just compare the average outcome of the treated group to the average outcome of the untreated group. Let's call that difference skew, the average predictive effect. Seems logical, right?
It seems logical, but here's the kicker. That observed difference almost never equals the true causal effect.
Why not? What's the gap?
That gap is selection bias. It's the systematic difference between the people who choose the treatment and those who don't, aside from the treatment itself.
Okay, walk us through that marijuana and longevity example you mentioned. That sounded like a good illustration.
Right. So let's imagine, purely hypothetically, that smoking marijuana has absolutely zero causal effect on how long you live. So the true ATE is 0.
Okay, no effect.
But in the real world, if we just observe people, those who choose to smoke marijuana might also, on average, do other things that do affect longevity. Maybe they drink more, maybe they have different diets, maybe less access to healthcare, whatever.
Right, confounding factors.
Exactly. So these other factors do cause shorter lives. Now, if we just compare the observed average lifespan of smokers versus non-smokers, we might find smokers live shorter lives.
And we'd wrongly conclude marijuana causes shorter lives.
Precisely. That difference we see isn't the effect of marijuana, it's driven by the other differences between the groups. The treatment smoking is tangled up with these other causal factors. That selection bias biting us.
That makes it crystal clear. So faced with this huge problem, this selection bias that seems almost unavoidable in observational data, what's the magic trick of RCTs? How do they solve it?
The magic, if you want to call it that, is random assignment. It's the cornerstone. Meaning who gets the treatment, D1, and who gets the control, DDOA, is decided purely by chance. Like flipping a coin, drawing straws, using a random number generator. Crucially, the assignment is totally unrelated to any characteristic of the person, their health, their choices, their income, anything.
Well, we sometimes hear the term exogeneity here.
Yes, that's the technical term. The treatment assignment D is exogenous, meaning it's not determined by anything within the system we're studying, especially not by the potential outcomes Y1 or Y0. It comes from outside, from the flip of a coin.
And what does that random assignment do? Why is it the gold standard?
Because of a really fundamental result in statistics. Under random assignment, selection bias disappears. It's mathematically guaranteed to be 0 on average.
Yeah.
Because randomization makes the two groups' treatment and control statistically equivalent on average before the treatment even starts. Any differences between them are just due to random chance, not systematic selection.
So if the groups are the same on average to begin with, any difference we see after the treatment must be due to the treatment itself.
Exactly. The observed difference in average outcomes between the groups now actually equals the true average treatment effect. EYD1 correctly estimates EY1, and EYD0 correctly estimates EY0. Randomization gives us a fair comparison. That's its power.
And this isn't just theory. That Pfizer BioNTech COVID vaccine trial you mentioned is a perfect example, right? A massive real-world RCT.
Absolutely textbook case. It was a double-blind randomized controlled trial. Volunteers randomly got the vaccine or a placebo.
And double-blind, meaning?
Meaning neither the participants nor the doctors assessing them knew who got the real vaccine and who got the placebo. That prevents expectations or biases from creeping in.
Super important. So what were the results? The numbers must have been pretty stark.
They were incredibly stark. In the treatment group, the ones who got the vaccine, there were only 9 COVID cases out of nearly 20,000 people.
Wow, only 9.
Compare that to the control group, the placebo group, 169 cases out of about 20,000 people.
Huge difference.
Massive. Calculating the ATE, it came out to a reduction of about 793 cases per 100,000 people. Clear evidence the vaccine caused this reduction.
And the efficacy number we heard so much about.
Right, the vaccine efficacy, or VE, that's a relative measure. It was calculated at 94.6% with a very high degree of confidence.
Impressive.
And there was an interesting statistical point, too. For older age groups, like 65 plus Sarah, the initial simple calculations gave a slightly wider confidence range for efficacy. But using more refined statistical tests, specifically designed for situations with fewer events, like they saw in the older vaccinated group, they were able to confirm strong efficacy with a tighter, more accurate interval. It just shows that even with perfect randomization, the statistical tools you use to analyze the results matter.
Okay, so RCTs eliminate bias through randomization, but often we know things about the participants before the trial starts, right? Like their age, maybe their prior health status, income. These pre-treatment characteristics or covariates, can we use that information somehow?
Yes, definitely. Using these pre-treatment covariates is often a very good idea.
Why? What's the benefit?
2 main reasons. First, you can often use them to get a more precise estimate of the average treatment effect. Basically, you can account for some of the random noise in the outcome that's just due to these baseline differences.
Sort of sharper estimate.
Exactly. And second, you can use covariates to explore heterogeneity. Does the treatment work differently for different types of people? Like, does the job program help younger workers more than older workers? This gets us into conditional average treatment effects, or Kate's the effect conditional on certain characteristics.
That sounds really valuable. But you hinted earlier there's a potential pitfall when using extra variables.
Ah, yes, the big warning sign. Never, ever condition on or adjust for post-treatment variables.
Why not?
Because if a variable is measured after the treatment starts, it might have been affected by the treatment itself. If you control for something that's part of the outcome pathway, you can accidentally control away some of the real treatment effect. Or if people drop out differently from the treatment and control groups after the study begins, adjusting for that can reintroduce bias. Stick to pre-treatment variables.
Got it. Pre-treatment good, post-treatment bad. Now, how do we check if the randomization actually worked? Did we really get balanced groups?
That's where covariate balance checks come in. Before you even look at the outcomes, you should check if your pre-treatment covariates look similar, on average, across the treatment and control groups.
So average age should be about the same, proportion of men and women, etc.
Exactly. If the randomization was done correctly, you shouldn't be able to predict who got the treatment just by looking at their baseline characteristics. Minor imbalances might occur by chance, especially in smaller studies, but large systematic differences are a red flag.
Okay, so assuming we have good balance and we want to use these covariates to improve precision, our source mentions two main regression approaches. One's called classical additive, the other interactive. Can you explain the difference?
Sure. The classical additive approach is probably what many people think of first. You just add the covariates into your regression model alongside the treatment indicator.
So outcome depends on treatment plus covariate 1 plus covariate 2.
Right. This can work to improve precision, but it kind of relies on the assumption that the relationship between the covariates and the outcome is linear and the same in both the treatment and control groups. If that assumption isn't quite right, you might not gain much precision. Or, in some weird cases, you might even lose some.
Okay. So what about the interactive approach?
The interactive approach is generally more robust and, frankly, often better. Here, you allow the effect of the covariates to be different in the treatment group versus the control group. You interact the treatment indicator with the covariates.
What does that mean, interact?
It means the model includes terms for the treatment, terms for the covariates, and terms that are the treatment multiplied by the covariates. This allows the slope of the relationship between a covariate and the outcome to differ depending on whether someone got the treatment or not.
And why is that better?
Because it's guaranteed to improve precision for the AE estimate, or at least not make it worse, compared to the simple difference in means, regardless of whether that simple additive model is perfectly correct. It adapts better to the data. Plus, it directly lets you estimate how the treatment effect itself varies with the covariates, that heterogeneity we talked about.
So the interactive method seems like the winner generally. Does it work in practice? Is there an example?
Absolutely. That U.S. Department of Labor Reemployment Bonus experiment from the 80s is a great case study.
Remind us what they did.
They took people claiming unemployment insurance, UI, and randomly assigned them. Some were controls, under standard UI rules. Others were in treatment groups offered incentives, like a cash bonus if they found work quickly and stayed employed.
Okay.
They wanted to see if these bonuses reduced the duration of unemployment. When they analyzed the results, they found about an 8% decrease in unemployment duration for one of the main bonus groups.
And did using covariates help?
Yes. When they compared the simple difference between the treated and control groups to estimates using either the additive or interactive regression adjustments with pre-treatment covariates like age, education, previous earnings, both regression methods gave slightly more precise estimates. The standard errors were smaller.
So tighter results.
Right. And interestingly, the regression methods also helped correct for some minor imbalances that occurred by chance during the randomization. Maybe slightly more older workers ended up assigned later on. The regression automatically accounts for that, giving a cleaner estimate of the bonus's true average effect.
That's really neat how it can fine-tune the results. Now, you mentioned causal diagrams earlier. How do they help visualize what's going on in an RCT?
They're super useful for laying out the assumptions visually. You draw nodes for variables, treatment D, outcome Y, pre-treatment covariates. W arrows show causal links or dependencies.
So for an RCT,
you draw an arrow from D to Y because we think the treatment causes a change in the outcome. You'd likely draw arrows from W to Y because things like age or education probably affect the outcome too.
Okay.
But crucially, because of random assignment, there's no arrow going from W to D. Your baseline characteristics don't determine whether you get the treatment. That independence is key, and the diagram makes it obvious.
Nice visual summary. Okay, we've sung the praises of RCTs, the gold standard, but we know they're not perfect. Let's talk about the dark side, the limitations. This is really important.
Hugely important. The first big one goes back to that SUTVA assumption specifically, the no interference part.
where one person's treatment doesn't affect another's outcome. When does that break down?
Think about large-scale interventions. Vaccines are a classic example again. If only a few people in a trial get vaccinated, it probably doesn't affect the unvaccinated group's risk much. SUTVA holds. But if you vaccinate a huge portion of the population, you might get herd immunity. The disease spreads less overall, so even the unvaccinated control group might see their risk go down.
Ah, so the control group outcome is now affected by the treatment being given widely. Interference.
Exactly. It makes the simple comparison harder to interpret as just the individual effect. This is partly why measures like vaccine efficacy, VE, which look at relative risk reduction, can sometimes be more stable in these situations.
Are there economic examples too?
Definitely. Think about education. If just a few more people get a college degree, they likely see a nice wage boost. But if everyone suddenly gets a degree, the whole labor market might shift. The value of that degree, the wage premium, might actually fall because it's no longer scarce. Your outcome depends on how many others also got the treatment. Training programs can have similar general equilibrium or spillover effects.
That makes total sense. So SCTVA violations are one major issue. What else limits RCTs?
Well, ethics, plain and simple. Many potential RCTs are just unethical to conduct.
Right, you mentioned the smoking example.
Yeah, the Belmont Report from the 70s laid out core principles: respect for persons, beneficence, do no harm, justice. You simply cannot randomly assign people to something you know is harmful, like forcing them to smoke, or withhold a treatment you know is highly beneficial just to see what happens. Beneficence forbids it.
Absolutely critical. What about practical hurdles?
Oh, plenty of those. RCTs can be incredibly expensive. The cost of the treatment, tracking participants, collecting detailed data, it adds up, especially if you need large samples for statistical power.
And time.
Time is a big one. Studying long-term outcomes means running trials for years, even decades. And over that time, people move, lose contact, or just drop out. That's attrition, and it can seriously compromise the results if it's not random.
Politics, too, I imagine.
Political feasibility is huge. Imagine trying to randomly assign access to a really popular new government benefit or a scarce resource. It can be seen as unfair and face massive public or political opposition. Sometimes it's just not possible to implement randomization in the real world.
Okay, so even if you overcome the ethical, practical, and SUTVA issues, and you run a perfect RCT, there's still another potential problem, right?
Yes, and it's a big one. Generalizability, or external validity.
Meaning the results might not apply elsewhere.
Exactly. An RCT gives you a very clean estimate of the causal effect in the specific population, setting, and time period where it was conducted. But will that same effect hold if you try the program in a different city with a different population, implemented by different people, maybe 10 years later?
Not necessarily.
Not necessarily. Local conditions matter. How the treatment is actually delivered might vary slightly. The scale might be different. What works as a small pilot might not work when scaled up nationwide due to those equilibrium effects we talked about. So the local truth found in an RCT might not be a universal truth.
That's a really crucial point to remember when we see headlines about study results.
Absolutely. Context is everything.
So we've journeyed from this 17th century idea of counting funerals through the elegance of random assignment, using covariates to sharpen our view, all the way to the very real, practical, and ethical limits of RCTs.
Yeah, it's quite a landscape.
You've seen how they're fundamental in medicine, policy, even tech, with all the A/B testing online.
Right. And the key takeaway, I think, is that while RCTs are the gold standard for establishing causality, they're not magic. They answer specific questions under specific conditions.
Understanding those conditions, those strengths and limitations.
That's what lets you be a critical consumer of evidence. Whether you're reading the news, making a business decision, or looking at scientific research, you can ask, was this an RCT? If not, what biases might be present? If it was an RCT, do the results likely generalize to the situation I care about?
It really equips you to think more clearly about cause and effect.
It does. So now that you've taken this deep dive with us, here's something to ponder. What's one area, maybe in your own life, maybe in your work, where you might now pause and rethink how you're attributing cause and effect based on what we've discussed?